Good evening, everybody. We've got three presentations, one short one. Our main presentation from our previous president. And Dewey's he's got kicked to last place.
2 minutes.
And I'm gonna skip the intro, except to say that there's no apiary on Easter. Apiary Day is canceled. So let me introduce you to Julia O'Connor, who's asked to present on her project, Nectar and Pollen Plants in North America. So Julia, I'll hand it over to you if you could do a little introduction.
Happy to. Thank you so much. So I moved to the high desert of Central Oregon in 2020, and I retired in late 2024. And in early 2020, spring of 2025, I got to do something I've wanted to do for a very long time, which was become a beekeeper. And when I did that, I found that all of the flowers in my yard, of which there are many, were planted really for butterflies and hummingbirds, not so much for honeybees. So I went on a mission to try and figure out how I was going to re-landscape to not lose what I had for the butterflies and the hummingbirds, but to also add plants that were particularly attractive to bees, honeybees in particular. And my goal was to put together a landscape that provided season-long great sustenance for my bees. And what I found was that many of the plants that I was looking at either provided great sustenance, marginal sustenance, or no sustenance, because my bees either couldn't access the pollen or they just didn't like the plant. And what I found out was that attraction for bees is sort of like how people are attracted to food. We might all like ice cream, but that doesn't mean that it's necessarily good for us, or at least not good for us if that's all we eat. So I went and tried to figure out how to determine what plants I should plant so that I achieve my goal of great nutrition over the entire season for my bees. And if we could go on to not the next slide, but the one after that, because I've already covered the next slide. And what I found was that there's very limited data available to me for me to understand what to do. First, there are very few lists of plants that are specific to honeybees versus pollinators generally. And there's very limited data on the nutritional value of specific plants. What is there is often conflicting and not necessarily derived from good scientific investigation. And I started talking to some people at OSU, and they understood my problem and told me about a project that they were working on and pointed out that one of their issues is that in order to analyze the nutritional value of pollen, what its protein content is, or the nutritional value of nectar, what its sugar content is, and in fact, if you look at protein, we also care about things like essential amino acids, micronutrients, minerals, etc. None of that analysis is free. It all requires people and equipment. And even if the university already owns the equipment, the department is charged money for using that equipment to help pay for the acquisition cost, the maintenance cost, etc. of that equipment. So in addition to there not being good data, there also is a need to be able to pay for the analysis. So with those two issues in mind, good data and the cost of analysis, OSU had a project, and I've been helping them promote this project and build it out and think about it from the perspective of the beekeeper as opposed to from the perspective of the scientist. Okay, and that project is geared toward creating a database of the plants that bees are attracted to. And the goal of the database is to be able to build a short list of what the bees are attracted to, and then go analyze. Obviously, you have to collect the pollen and the nectar from that short list of plants, the ones that the bees are most attracted to. Once you have that short list and you've collected some pollen and nectar samples, then you start with an analysis of the nutritional value of those plants and sort of work your way down. And so ultimately, the goal of this project is to build this database that will tell us which plants provide great nutrition and what combination of plants should we put in our bee yards to provide that great nutrition over the entire season. Next slide, please. We missed one.
So there's 3, there's 4, there's 5.
Okay, I'm not sure how. Okay, so maybe I left one out. So one of the things I want to sort of give people an idea of how variable the data is that's out there right now and why it is so important that we do more research on it. If you look at the protein content of pollen that's on lists that are pollinator lists, that protein content can vary between 2.5% and 61% across the range of plants. If you look at one particular plant like the vine maple tree, which is native to the Pacific Northwest, different studies show that the protein content varies between 27% and 58%. So even if you do have a study of a specific plant and multiple studies of that plant, you don't necessarily get consistent data that you can look at and say, ah, I believe that data. There is very limited data on essential amino acids. And if you don't have the right combination of amino acids, then the bees can't process the pollen. The protein is not useful to them. And it's not even clear exactly what amino acids are essential. Similarly for nectar, if you look at the sugar concentration, it can vary between 1% and 73%. And some plants that we think are great bee plants, like cleome, which is also known as the spider flower or the bee plant, cleome nectar is only 22% sugar. On the other hand, borage, which is called bee balm, its sugar content is 52%. So even these two plants that are supposed to be just great for bees, in fact, bees are in their common names, have widely different amounts of sugar in their nectar. So the goal is to have us beekeepers collect data so that we can come up with the short list. And how do you help? You help by downloading an app. We use an app from iNaturalist, iNaturalist.org. The app is available for iOS and Android, and it uses your camera. And you open the app, which then you tell it you want to take a picture. It opens your camera, you take a picture. It captures the picture. It captures your location. It uses its data to help you identify the plant. And you answer a couple of questions about your observation. Like, how many, are there a lot of bees on it? A few, hardly any? Is the bee collecting pollen? And if so, what color is the pollen? And when you submit that, that goes into this database that we will use to come up with the short list of plants. You can also just take pictures on your phone and then go on your computer, go to the app and upload the pictures and enter the data on your computer if you don't want to deal with your mobile phone while you're in the apiary, or on your walk, or wherever you are that you see a honeybee on a plant. Okay. Next slide. So is it a big time commitment? Absolutely not. You can record as often as you would like. And we actually don't want you to submit more than once per day per flower species per location. So if you have half a dozen lavender plants and half a dozen catmint plants, you're only going to submit at most one observation per plant species per day. And if you don't do it every day, that's okay. You can do it whenever you're out and about. I think I already talked about the process. Pretty easy. You're adding like your picture and 3 pieces of data. Next slide. So to volunteer, you simply download the app. You create an account. It's free. And then you join, and then you get there's a menu, and you go and look at projects, and it'll allow you to search, and you search for nectar and pollen plants of North America, and you select join. And now you're ready to submit observations. It couldn't be easier. It's very easy. Next slide. We talked about this. Take a picture. Tell me tell me the level of honeybee activity, a little, a lot. If they're collecting pollen, check a box. Pick a color of what color the pollen is and hit submit. If you're not sure, next slide. If you're not sure exactly what the plant is, it will help you figure it out. And to do that, if you can, take a couple different views of the picture of the flower. A close-up, a real big close-up that shows the whole flower, a close-up of the leaf, and something that shows like the whole plant. And to the extent that you're not sure, or to the extent that there are multiple varietals of there are multiple species that look a lot alike, or there are multiple varietals of the same species, then you're going to help the researchers confirm that the plant that you think it is in fact what it really is. And the varietals are relevant, right? So I have apple trees in my yard, and they're all going to come under malice. And every time I take a picture of a bee on an apple blossom, it'll go under malice. But I'm going to put in the notes section if it was a Brayburn, or if it was a Northern Spy, or if it was a Honeycrisp, because those are varietals of malice. But if I didn't, that would be okay. The species is the important thing. So we're really hoping that we can get a lot of beekeepers to help us this year and collect data, as much data as we can, without it being an imposition. We don't want it to become burdensome. We want it to be part of what you're enjoying. You keep bees. If you keep bees, you enjoy being outside, and you enjoy the plants that they pollinate. So please help us. Questions? Oh, and then there's one final slide that has my email address on it. We talked about that. And if you have questions, don't hesitate to email me.
That's great.
Questions?
I use that app for the melitologist program, and it's great just for logging observations when you're out and about. Super easy.
Very easy.
Yeah.
So, and we used to require that you get a picture of the bee on the flower. That was the hardest part. We don't do that anymore. We trust that if you say it's a honeybee on the flower, you know what a honeybee looks like. And you just need to take a picture of the flower so that we can confirm that we've got the right species and the right varietal.
Okay. Anybody here? Questions on this side? No, I think we can send your presentation via email as well to the membership for
That'd be
awareness.
great. That way they have the information, the detailed information about how to make an observation, what if you have this or that or the other thing, and they have my email address.
Okay. Great.
Thank
Well,
you
thank
very
you.
much. Appreciate
Thanks.
it.
Please stick around and listen to the rest of our presentations, and
Awesome.
I'll take you off the spotlight here. So, and little spotlight. Okay. And you are reactions in the hive. No, just tell me to advance. I'm the clicker. High tech. Slideshow from beginning.
How do you want that? In front of that camera?
Yeah, in front of the camera.
Hi, so my name's Cheryl Wright. I'm a nurse practitioner and a beekeeper. I went through the Oregon Master Beekeeper program and can't say enough about it. It's fabulous. And I also worked with an allergist for a couple of years. And so that's where my real interest in allergy came forth. So I decided that, you know, I'd kind of spread the word about allergies in the beehive. So we all think about bee sting allergies, and that was when I presented it a couple of times. I really focused on the bee sting itself. But I thought, well, the more I read, the more I realized that there's actually a lot of things in the beehive someone can be allergic to. So slide, please. So kind of how we're going to do this is we're going to talk about the significance of allergies and bee stings. We're going to talk about what stung you. We're going to look at venom characteristics, and we're going to talk about different reactions and the pathophysiology, the inflammatory response, which is expected, and then unexpected reactions. And then we're going to get down into hypersensitivity or anaphylaxis and the pharmacology of anaphylaxis. And then we're going to talk a little bit about immunology, which is how we can make this go away. It's like magic. Next slide.
Oops.
Okay, so the most important thing I want you to take away from this is if you're a beekeeper, your risks of becoming allergic to bee stings is heightened because frequent exposure to bee stings does make you have more of a potential to be an anaphylactic responder. So of course that's us, but that's also firefighters, farmers, construction workers, truck drivers, and anyone who does a lot of hiking outside. So when I worked in the allergy clinic, and I'd say we saw maybe 5 patients in the year and a half I was there. And those 5 patients, 3 of them were beekeepers who had been keeping bees for years before they developed these symptoms. But the good news is that it is a relatively rare allergy. So for instance, in the 10 years between 2007 and 2017, there was about 62 deaths that were attributed to stinging insect allergies. But 80% of these people were men. And I just say that because I think more men are beekeepers and more men are out and really exposing themselves. And when you look at the YouGov poll in 2022, we know that a lot of people get stung by bees, and 75% of Americans have been stung by a bee. But the true allergic rate, the true allergy rate is about 1.6 to 5.8% of the United States citizens. So we have to think about if we find a beekeeper, we think this might be underrepresented. This number may be underrepresented. Because death can be inappropriately or inaccurately attributed to a bee sting when it might have been something else. So if we have a guy out there working bees and he has a cardiac risk factors, he's maybe a white male, he's 60, he's smoking, and he's out there, he gets stung by a bee and he drops dead. Well, was it an anaphylactic reaction or was it a myocardial infarction? So we don't really know. So that 1.6 to 5.8% of these suspicions of this allergy and that 62 deaths per year is there's wiggle room there. Next slide. And so I want to just digress quickly. Bee sting is the big focus, but there are things that people can also be allergic to. So there is a true honey allergy. A lot of times we see this like any other food allergy. It can happen to a child, it can happen to an adult. So if you know somebody who's had honey and they've complained of the symptoms of an itchy throat or severe nausea or vomiting or diarrhea after eating honey, it could be honey allergy. So, what about honey would make someone allergic? Well, we know there's fructose and glucose, and there's 17% with water, and there's trace enzymes and proteins in honey, vitamins. So one of the theories of how people are allergic to honey is that maybe it's the pollen in the honey, but we know that bees are pollinating things like cherry trees and apple trees. Most of the people who are allergic to pollen is grass, trees, and weed pollen. So these are the pollens that are transmitted through the air, not insect or delivered pollens. So that's unlikely that, not many people are allergic to cherry tree pollen. We think one theory is that as the bees are walking across the comb, that maybe they're dropping venom on the honey, but that's also unlikely. So we're not really sure. We think it's actually a true honey allergy. So again, if you feed a kid a peanut butter and honey sandwich and they start having, allergic reactions, yes, it might be the peanut, likely, but it can also be the honey. So skin prick test figures it out. Next slide. So you can't see the top of this, but propolis is a component of the hive that a lot of people harvest and use, especially I've noticed a lot of Russian people will take it and make tinctures and they'll drink it, rub it on themselves or whatever. And it can be quite an irritating thing to the skin. So the question is it a true allergy or is it just an irritant? So you have to understand the difference between a contact dermatitis, which is where the skin doesn't like it, it kind of rashes out, or is it a true allergic reaction, which is where the immune system is actually doing something different. Really not liking it. And chronic skin irritation can lead to a true allergy. If the skin is constantly irritated and exposed to something, you can develop an allergy to it. So in the literature, it's reported like skin changes when people put propolis on, rash, mouth sores. If it's just an irritant, it will happen pretty quickly after exposure. If it's a type 1 anaphylactic reaction, again, they'll have itchiness, they'll have swelling, it'll become a systemic reaction. Or it can be a type 4 delayed hypersensitivity, which the person puts it on and then an hour, 2 hours, or even days later, they can develop a reaction to it. And again, you can see an allergist and they can figure this out for you. But you will have to take your propolis to the allergist so that he can test you with it. Next slide. So I just want to back up and put it all into perspective because the top 5 causes of death in the United States are not bee sting allergies. They are usually lifestyle issues. So heart disease, cancer, accidents, stroke, and chronic lower respiratory diseases. So if you just stop smoking and exercise, you'll be healthier. Next slide. So let's talk about what stung you. So next slide. So we all know the honeybee. We love the honeybee. Next slide. And most people here know that right now we're in swarm season. A lot of lay people aren't really sure about this, but we know that when honeybees are swarming, they're not aggressive. This is not a defensive or aggressive behavior. Next slide. And we see this with, the people who put the little queen on their neck and let the bees walk all over them. They're actually quite sweet little creatures, unless you're squashing them or invading their hive. Next slide. And then I was reading my American Bee Journal, which I dutifully do to keep myself up to date, and I was surprised that this month's journal had a little commentary article by a fellow named Loper, who said that when he was working bees in 1993, he was exposed to the African honeybee aerosolized venom, and he had all this damage done to his upper airways. And I thought, wait a minute, I've never heard about that before. Aerosolized venom, what the heck, right? Never heard of this. So I did a little literature search, and Rusty Burlew, who many people know here, she's a scientist and an author at Honeybee Suite. She said, yes, she too has heard about this, sprayed venom, but she did some more research too, and we come to the conclusion that venom can pretty much only be injected. That is the mechanism. And what her theory was that people who were having this burning skin, eyes, even breathing it into their airways and having airway damage, which this guy Wilbur said he did through a bronchoscopy, are probably having a reaction to the alarm pheromones, which are aerosolized, and they have very irritating chemicals, the alarm pheromone does. So those are some of the chemicals that are there. So just in case you guys read that article and thought, wow, what about sprayed venom? Probably not. Next slide. So if we keep bees, we're going to probably get stung by bees. This is who I'm speaking to, beekeepers. So great. Next slide. But what I want everybody to remember, and probably everybody here is aware, is that the honeybee sting is barbed. And so not only is it barbed, but it has an attachment to it that you can barely see in the slide in the upper right-hand corner. But next slide. This is a cartoon of what's going on. So when the honeybee stings you, she darts you, that stinger is staying in place, and there's a venom sac, and then below that is a diaphragm that's actually pumping the venom in. So it just behooves you that if you get stung, that you get that stinger out as quickly as possible, or at least break the venom sac off and get it separated so it's not continuing to go on your skin. Next slide. Also, that the bumblebees this time of year are nesting. So if you kick over a bumblebee nest or you get into them, they will sting. And so honeybees and bumblebees have a cross reactivity. So if you're allergic to honeybee, you most likely are going to be allergic to bumblebee and vice versa. Next slide. So paper wasp are the guys who are living up in your eaves, and they are beneficial insects or pollinators. They eat garden pests, and they're not going to sting you unless you get in there and bother them. So I just think that's important because I don't think we should be going around spraying and killing all these other pollinators. They're the good guys too. Next slide. And paper wasp again, they can look like that. Next slide. Yellow jackets are another type of wasp, which we call, well, I guess I shouldn't say it in public, but they're the bad guys with wings, and these people are really super aggressive. So these are the guys who you got your little 5-year-old out in August eating hot dog and Coke, and these yellow jackets will be very aggressive trying to get that food away from the child. Next slide. Next slide. They do not have a barbed stinger, therefore they can stand on your arm and sting you as many times as you're willing to watch them sting you, and they have no qualms. Next slide. And they can also bite you, which hurts a lot, but there's no venom in the bite. It's just very unpleasant. Next slide. Now, bald-faced hornets are less aggressive towards us than the yellow jackets, unless you kick their hornet's nest, and we all know that. So if you see the hornet's nest and you are a beekeeper, it's probably a good idea to call someone to get rid of it, because both the yellow jackets and the bald-faced hornets, in case you don't know this, predate heavily on weak hives. So they will take your hive out if it's a weak hive. Next slide. So this is just a group of the characters that we're dealing with in the Pacific Northwest: honeybee, wasp, yellow jacket, bald-faced hornet, and next slide. So next slide. So it's important to understand this slide. This is a kind of a busy slide. What we've done is we've broken it down into the honeybee, the yellow jacket, and the wasp, and the hornet, their venom characteristics. So if you look at the honeybee, it has melatonin, 50%, 55% of the dry venom is melatonin. Apimin and the mast cell degranulation peptide, and that's very allergenic. If you go down, let's kind of cut off the bottom. If you go down to the very bottom row, can we shrink it a little bit? you can see that for the lethal doses of venom, it takes less honeybee venom than it does yellow jacket or wasp venom, or hornet venom to actually kill you. So that's the lethality of it. But what I want you to take away from this slide is that wasp has its own little set of things. So the wasp kinin, the mastoperin is the equivalent in wasp to the mast cell degranulation peptide, the MCP peptide. And those are the things that specifically break the cells and release in the histamine into your system. And then hornet has its own hornet kinin that's separate, but all of them have that final common pathway, the phospholipase A, B, and polygonidase, and then the alarm pheromones. So this is why no matter what stings you, going to an allergist is a good idea, because you may think that you're reacting to yellow jacket, but when we test you against all of them, you may have actually been reacting to the phospholipase A or B, and you may have a broad range in stinging insect allergy rather than just a honeybee allergy. Next slide. And these are sort of the characteristics. If you're really interested, you can go back and read these slides online. But this is what the venom itself is doing. So the melatonin is a peptide and major toxic compound in the honeybee, and it's just breaking down cells. So all of these chemicals are designed to just break these cells down. Apamine can go through the blood-brain barrier, which in medicine is a big deal. Anything that can get into the central nervous system, we all get really excited about. The mast cell degranulation peptide is breaking the mast cells. And this is what's causing you to have the itching. And the mastoperin, same thing, is causing you to have itching, maybe a little hives. And then hyaluronidase, these are things that are also breaking down carbohydrate and protein bonds so that these the venom can get even deeper into the tissues. And then the phospholipases, A and B, again, they're just breaking cell membranes, and they're just decimating the area where this venom is. And then, of course, we all know what the pheromones are doing. They're saying, hey, girls, let's have a party here. Next slide. There's other additional venom characteristics. So some of these substances are found in our body. So histamine is in our body, but the sting itself also has histamine. Serotonin is in our body. We make it, but it's also in the sting. And all of these chemicals are coming together to make this as painful and as irritating and as problematic for the victim as possible. And when you think about what these guys are dealing with, bees, they're dealing with bears. So, they're going up noses, in eyes, in ears, and that's what they're kind of honing in. That's why they'll go into your hair and they'll burrow down. And so that's why it's so important to wear a veil, because getting stung in the eye or having a bee up your nose, stinging up the nose or in your ear. When I used to work in the emergency room, if we had any kind of insect in the ear, it was considered a medical emergency. So if that happens to you, if you have mineral oil, you want to instill that into the ear. But so just wear a veil if you wear nothing else. Next slide. So before and immediately after the sting. So if you notice yellow jackets are on the ground and they're agitated, move away from them. If you're mowing the yard and you mow over them and you irritate them, leave. Don't hang around. And if you're in your own hive and your bees are starting to get real agitated and you haven't got your smoker going, don't squash them, because that's just going to release alarm pheromone and it's just going to make everybody more angry. And it's funny because these insects, they also we all know this, if you've dealt with bees, they just hate it if you swat at them. So, you just have to grit your teeth and just calmly move away if you can, or run. But once you've been stung, try to find the stinger. I mean, if you get stung in the head, run your fingers through your scalp, find that stinger, get it out. Because an 8-second delay in getting that stinger out can worsen your reaction by 30%. So we're talking about a lot of swelling and a lot of pain. Ice it as soon as practical, elevate it if it's on an extremity, and then you can take an antihistamine of choice like Benadryl, which will make you tired, so don't drive, or Zyrtec, and then a non-steroidal anti-inflammatory like ibuprofen if it's not contraindicated for you. Next slide. So now let's talk about sting reaction and the pathophysiology. So just exactly what happened. Next slide. So the types of reactions that anybody can have when they're stung, or actually exposed to anything, is your expected inflammatory response. You stub your toe, you hit your finger with a hammer, and you're going to have inflammation. And that's what the bee sting will do. A large or wide local reaction is not normal in the bee sting. And if this happens, this is your warning that the next sting could be a full-on anaphylaxis. There's delayed hypersensitivity type 4, which will look like serum sickness, and that's not life-threatening. Toxic or excessive envenomation, if you haven't reached that lethal level of venom that we talked about earlier. We'll talk about that, and then allergic type 1 hypersensitivity, which is an anaphylaxis. Next. So the inflammatory response. Next slide. So this is a non-specific defense mechanism, and it's designed to neutralize chemicals and microorganisms. So if you break the skin, you have the swelling, the redness, and that's trying to keep you from like getting an infection and developing gangrene. This can be an acute or chronic problem. If it's an acute problem, it's going to be 8 to 10 days. It's going to get better. And then there's the chemical mediators of inflammation, which are the histamines, the prions, bradykinin, complement, prostaglandins. All of those things are normal. And then histamine. And histamine is just really everywhere. So it's in your skin, it's in your airway, it's in your GI tract, and in all your blood vessels. And that's going to be important later when we talk about anaphylaxis. Next slide. So this is just a cartoon that kind of shows you what happens when you stub your toe or you get stung by a bee. Your blood vessels are going to dilate. The blood vessels are going to become leaky. You're going to get swelling. There's going to be cellular infiltration, which is where the white blood cells come in, and that looks like pus. You're going to have microthrombosis, little bitty clots, and that's all part of the healing system. And then all these nerve endings are going to get stimulated, and that's the pain part, which says lay down, elevate it, let us do our job. Let the immune system take care of this. Next slide. So again, as I said, this is the expected reaction to an insect sting. You're going to have a lot of pain, probably for about 10 minutes, local swelling, itchy, and within 5 to 7 days should be completely gone. Everybody in this room has experienced this, I'm sure. In pharmacology, basically your antihistamine of choice is just going to help with the itching, and non-steroidal, the ibuprofen, once again, will just help with the swelling and the pain. Fine. So here are some examples of normal reactions to these things. Again, wear your veil. This, while it's not a sting emergency, it could be an ocular urgency. So you might want to, if you get stung in or near your eye, see urgent care, or and just make sure that the swelling goes down. There hasn't actually been injury to the eye. But you can see the hand, it's poofy, swollen, a little bit of redness. Both hands are fine. This one on the lower right hand, I just say take your rings off if you're going to work with your bees, or you might have to have them cut off in the emergency room. Next slide. And again, this is another example of a normal reaction. And we're going to talk about this a little bit more when we talk about the wide local. But you can see that she was stung on the pinky finger. And you can see that there's swelling, and the swelling is, going past a couple of joint lines on the fingers. But this is kind of what we call poofy swelling. It's not hard swelling. You can push it down. It's just kind of fluffy. Next slide. So now let's talk about unexpected reactions. Next slide. So these abnormal or unexpected reactions are a large or wide local reaction. Again, this is your warning, the delayed hypersensitivity 4, the toxic excessive envenomation, and then the type 1 anaphylaxis. Next slide. So a large or wide local reaction. So this is very likely a warning for your future anaphylactic reaction. It's seen in beekeepers. Again, we get multiple stings per season, but it's another reason to just not be super cavalier about it. Oh yes, my arthritis gets better when I get stung. I let myself get stung. I mean, it's just not a great idea. It's characterized by unusual swelling. So if, for example, you're stung on your finger or your hand and the swelling is more than 4 to 6 inches in diameter, when we're talking about hard swelling, we call it induration. It's not swelling that you can press down, okay? And it's painful. But more importantly, you may, even if you don't get this wide local reaction as a sting feature, another idea of a wide local reaction is any other symptom that you might get. If you get a patch of hives on your shoulder, that's a problem. If you get any chest tightness, a runny nose, itchy eyes, you start tearing, any facial swelling, anything like that is a big problem, because your next sting could be an anaphylactic reaction. So if you have any of those symptoms, you need to get your skin tested and then a blood test to confirm, and then take next steps. Next slide. So this is an example of a wide local reaction. You can see to the left there that she holds her palm up to her arm. This is her forearm. And so if we consider that our palm is about 3 inches wide, and the length of our hand is usually a female, about 6 inches, you can see that that's a pretty big reaction. And you can also tell that it's indurated by the color. And if we were to touch it, it would be very firm. And most people would be concerned if they had something like this. And that's just another example. Next slide. So other unexpected reactions. So again, this bee stinging you, it's going through normal flora in your skin. If you get a bee sting, just wash it with soap and water. Don't get any infections. Next slide. This is a eosinophilic cellulitis. This is really super rare, but what's going to happen is you're going to get these blisters. And you're going to go to the doctor and they're going to treat you with antibiotics. And the way you're going to know that it wasn't just a regular cellulitis or infection is the antibiotics aren't going to do anything. It's just going to continue to sort of get worse or stay the same. So if that happens, we want to see a dermatologist and a skin biopsy, and then they can make that diagnosis. And then how does this affect you as a beekeeper? I mean, if you keep having these reactions, it's probably going to make you. Next slide. Now we're going to talk about the hypersensitivity. So there's type 1, which is anaphylaxis. There's type 4, which is a delayed reaction. The anaphylaxis is going to kill you. Type 2 and type 3 are something that happens in the hospital. We're not going to see that. Next slide. So this is what serum sickness looks like. So this is a type 4 delayed hypersensitivity reaction. This is really uncommon. It's not going to kill you. You should go see the doctor. But if you keep getting stung and having these reactions, it may limit your hobby in beekeeping. Next slide. And so serum sickness is a delayed hypersensitivity reaction. It's mediated by T cells. And it can happen when you're exposed to a lot of different things. Like I've got a guy in the allergy who had that exact rash, and he was working like at Precision Castparts, and one of his jobs was to clean things. And the chemical that he was cleaning with, just the vapor, with the volatiles, caused him to have a rash like that. But other metals, chemicals, medications, and then other things that can go along with the rash, you can have fever and joint pain. But again, it's not going to kill you. It can be uncomfortable. And the thing that makes it key is that it's delayed. So you're not going to get stung and have this rash. It's going to happen like 2-3 days later. Next slide. And then treatment, go see the doctor. They're going to give you topical steroids. They're going to give you oral antihistamines, cold compresses. You may, if it's severe, you're having a lot of joint pain, they may give you systemic corticosteroids, and then just ibuprofen if it's not working. Next slide. So now we've talked about the first two. Let's talk briefly about toxic excessive envenomation. Next slide. So there's no anti-venom for bees or wasps, but there is for some scorpions. So if you live in the desert Southwest and you get stung by a scorpion, as adults, we're going to be okay, but it actually kind of kills little kids. So they developed an anti-venom.
Right. But
for us, bees, not going to happen. So we do recommend that if you get an excess of stings, like more than 20 or 30 stings, that you probably should go to the emergency room just for observation and supportive care. The people who have been stung by the killer bees and have died have had a bee sting allergy. So this is not something like killer bees aren't really killing you, you have an allergy. So again, to reiterate that lethal honeybee venom dose is about 1,100 stings for an adult, or 2.8 milligrams per kilogram of venom per weight. So if it's a child, it's not going to take 1,100 stings, it's probably going to take less. But one Brazilian observational study looked at 11 people between the ages of 5 and 87 years old who received 20 to 500 stings from these Africanized honeybees. And the good news was nobody died, nobody had serious heart, kidney, brain, or nerve symptoms. Everybody had pain, swelling, and itching. More than half had elevated heart rate, high blood pressure, diarrhea, nausea, vomiting, and some anemia. And most developed some, a little bit of elevated white blood cells, neutrophils, and then creatine phosphokinase, which is an enzyme that's released when you have like a lot of cell death. So all normal things, all easily manageable. Next slide.
Normal.
So hypersensitivity. So now what I promised you, the anaphylactic reaction. Next slide. Okay, I want everybody understand that you can risk stratify for an anaphylactic reaction to bee stings. So certain people are more likely to experience anaphylaxis. These are people who have a prior diagnosis of allergic asthma, they've got a lot of pollen allergies, they have eczema, or they have other food allergies or a lot of medication allergies. Or they've had a prior anaphylactic reaction to anything. So that just lets you know who and what you're dealing with before you invite them over to your apiary. Next slide. So anaphylaxis is a severe reaction. It can develop quickly and can reach its peak severity in 3 to 30 minutes. So the important thing I want you to take away from this is it can be biphasic, which means that yes, you give yourself your epinephrine, you feel a little bit better, you have a second epi, you give yourself your second epi, you feel better, you go home, you take a nap, and like 4 to 8 hours later, the whole reaction can come back again, and that can kill you. Next slide. So anaphylactic reactions can include probably not all of these, but certainly you're going to have some of them. One is a sense of doom. And so this is in medicine, this is like everybody jokes about it. But then I had a friend who's a physician who had an anaphylactic reaction. And he said, you know, that sense of doom thing, it's a real thing. You really do feel like something really bad is about to happen. Or you can just immediately lose consciousness. Again, you can have a lot of swelling. And this is when I talked to you about the histamine being almost in all of your tissues. So all of your body can be affected, because this is just a huge cascading event. So swelling and redness around the eyes, redness in the white part of your eyes, hearing, itching, swelling of your tongue, lips, the roof of your mouth. Your skin can have redness, hives, itching, swelling. Your breathing is going to be affected. You can have upper airway obstruction from the swelling of the tongue, the oropharynx, your larynx, but then you can also have bronchospasms, so your lungs themselves are constricting down. You're going to feel tight, you're going to cough, you're going to wheeze, you're going to runny nose, sneezing, congestion. Cardiovascular, you can have faintness, low blood pressure, chest pain, irregular heartbeat, and then cardiovascular shock, and then complete fainting or syncope. Now, some of the things that are not as well known are the gastrointestinal symptoms. So you can just have intense abdominal pain, or you can have hyperperistalsis where everything starts moving really quickly, leading to fecal urgency or incontinence. And then in genitourinary, women can have just super intense uterine cramps very suddenly, urinary urgency or urinary incontinence. So again, this is all probably not going to happen at once, but any of these things, any 3 of these things, or any even one of these things is a big problem. Next slide. So this is just a picture of, it's not a bee sting, it's actually hereditary angioedema, but it gives you a sense of what your face might look like if you had an angioedema experience. So maybe you got stung on your finger, or your friend got stung on their finger, and 5 minutes later their face looks like that. Big problem. Next slide.
Yeah.
And these are what hives looks like on different skin tones and different types of hives. So you see in the top left, these are kind of like discrete little bumps, and then the top right, discrete little bumps. But then as you move down to the bottom left, things are starting to what we call coalesce. So that on the bottom right, what you're seeing is coalesced hives, which is kind of weird. Like, what am I looking at? What am I seeing? It's like kind of swollen, but not swollen. What is that? It's a bunch of hives coalesced. Next slide. So the pharmacology for anaphylaxis is really easy, okay? Epinephrine, antihistamine, steroids, and then inhaled beta agonists for wheezing, and then IV fluid. So you're really just treating people symptomatically, except for that epinephrine. That's what's saving people's lives. Next slide. So epinephrine is magic. It actually reverses everything that the bee sting does. It causes blood vessels to vasoconstrict. It causes leaky things to stop leaking. It opens airways. This is a super busy slide. We're not going to go into all the details, but the most important thing to understand is it's extremely short acting. So it can, you give it, that's why you buy an EpiPens, you get a 2-pack. So 5 minutes later, you need to administer the second dose. And if you're administering epinephrine, you should be calling 911 with your hand. Next slide. So the biggest mistake anybody can make in any kind of allergic reaction ever is to delay giving the antihistamine. Nobody wants to hit a kid with an 18 gauge needle, but do it, because if you try to delay and maybe give, let's give a little Benadryl, let's see if that helps. What you do is you get behind that cascade, you get behind the power curve. And so that is really a super unfortunate mistake. If you think somebody's having an allergic reaction, give the epinephrine. Next slide. So immunotherapy, this is where the magic happens. Next slide. So venom immunotherapy or desensitization, there's this big group of people called the Cochrane people, and they have a database, and they look at all these trials and they put all this information together, and they have said venom immunotherapy works. It's worth it. All the trials are really positive and good. We like it. And if a person has a wide local reaction, they should be tested and they should be treated as well. Don't wait for an anaphylactic reaction. Next slide. And this is a person who I met jogging down my road, 92nd Street, and she's on the road, car comes by, she steps off the road, steps into a yellow jacket nest, hit by about 20 yellow jackets, can't breathe, calls her husband, gets a call 911, don't know why. He came, took her to the emergency room, and then we saw her about 3 or 4 weeks later, and we tested her. And this is the beautiful thing I wanted to illustrate. So this is the positive control. So this is where we just stick antihistamine right into her arm. We want to make sure she hasn't had any Benadryl or anything that would knock our reactions out. If you see 1, 2, 3, 4 across her arm, what we've done there is those are the strengths of the venom that we're going to inject. And then this is wasp, honeybee, and all the different insects that we talked about earlier. And you can see that with the first pass, not much of a reaction, but by the second pass, she was completely positive on all. So what we know is that she was allergic to something further down in that final common pathway, not just yellow jacket. So she had to go through desensitization for all the stinging insects. Next slide.
So you didn't do 3, 4, and 5 at that point?
No, at that point, did we see that she's positive, so no sense in making her.
No need to keep
Yeah.
going.
We could have if we were just like in the mood, but. So venom immunotherapy it's kind of a time commitment, but it's really super cool because they actually take these venoms from the insects themselves. And they start off with very weak serums, and you get a little skin injection weekly as we build up for about 4 to 6 months. Every week you come in stronger, stronger, stronger. Then we reach maintenance, which is equivalent to 2 stings. So you're getting an injection now that's 2 insect stings once a month. Somebody's watching you very closely. Yes, you can have an anaphylactic reaction while we're doing this, but we have everything right there. It's no big deal. We can make it go away. And once we get to full strength, we do this every month for 5 years, and then after 5 years, you're cured. And it's just like magic. No more EpiPens, no more worrying about it. You'll never have an allergic reaction to this thing again. But what?
My daughter is still being treated at 7 years.
For insect stings?
Well, yellow jacket and honeybee.
I would just say that in our allergy clinic, that in the American Academy of Allergy says after 5 years, you should no longer be, but look.
I'll ask her
it's-
to double check.
It's right, it's
She's still carrying an EpiPen.
right, yeah, and all through desensitization for any allergy, you always carry an EpiPen. But yeah, next slide. In medicine, it's never, never, never always. And these are my references. Next slide. And the next slide. And those are my baby bees with my brilliant screen. Because I had to have workers come out and put a rail up, and so I had to keep my bees contained, and I didn't want to put anything else. Those are my robbing screens.
That's
Keep the
great.
bees out, and they loved it, and the workers loved it, and now I have a new decorator. Any questions?
Yeah,
Uh-huh.
so these things hurt, they itch. But I also get this euphoria feeling for a little bit. Can you explain that?
Yeah, that's an endorphin release, so anytime, yeah, it's just like the runner's high or anything.
It doesn't happen with the yellow jacket, so. Seems like, am I just imagining that?
I couldn't tell you. I would just, it's just a guess that it's just an endorphin release.
Question from the chat.
Mhm.
Did I understand that if Benadryl is given after a sting, it can interfere with other medical interventions?
No, what the take home from that was, if you think somebody's having an anaphylactic reaction, don't go to Benadryl. Go immediately to epinephrine. Don't delay don't delay that first aid, because that cascade can get out of hand really quickly. And if you're using Benadryl hoping that it's not an anaphylactic reaction, the patient can die.
easy to get the pens? How do you get them?
Can you come closer
Oh,
for
I'm
the
sorry.
microphone?
Okay. So.
And repeat the question.
Oh, so the question was, how easy is it to get EpiPens? So I do an EpiPen training through the Oregon Health Authority, which is really interesting because Oregon was one of the first states to like say, hey, look, you know, if people think that they're gonna be around someone who's gonna have anaphylaxis, why don't we just train our population to use EpiPens? So you get after the EpiPen training, which is it talks more about food allergies and pretty short training actually. Then I sign a yellow card for you and you take that yellow card to any pharmacy and then you can buy that EpiPens. You can buy them, but they're pretty expensive. So for people who want to like, you know, be that altruistic, it's about $250, the cheapest to carry a couple EpiPens around just because. If you're allergic, you can get them for yourself through your insurance company. If you're not allergic and you try to get them through your insurance company, that's a problem.
I've been told by my doctor that she would happily prescribe it for me since I'm a beekeeper, and I've heard that from other people as well.
Yeah, I mean,
So-
again, if she has done the education with you and you have the sense to know what looks like an allergic reaction and, you know, you want to take that liability and not be trained, that's fine. But if you do the training and then you screw up, like, you know, your 60-year-old male beekeeper drops dead and you say, oh, and you give him the epi and actually he was having a heart attack and instead of doing CPR, you gave him epinephrine, you actually made that problem worse.
Oh.
She was talking about using it, so.
There you go.
I also had another question.
Uh-huh.
My daughter and my sister's son are both reactive to both honeybees and wasps,
Mhm.
and in both cases, they go into anaphylaxis immediately.
Wow.
And I've been unable to find any information as to whether or not there's a genetic component.
Well, we know there's a genetic component. We don't know that, like we haven't found the gene, but we see it in families, but the allergist will not test you unless you've been stung. Insurance won't pay for it, let's put it that way. Unless you've been stung and you've had a wide local reaction or you've had something that's worrisome. So, but I do believe it's genetic.
I'm completely non-reactive. I've gotten stung up my nose and
Ouch.
it was painful for about a minute.
The Zoom call didn't hear the response on Benadryl. If you could give that again.
Sure, okay, so Benadryl's fine if you're having just a regular reaction and you know that you've been stung, you're not having any of the other symptoms, no itching of your throat, no hives, no swelling, no tearing, nothing that's worrisome. You get stung, you can take a little Benadryl for the itching of your skin. What we don't want you to do is have someone you think might be having an allergic reaction and try to avoid giving the epinephrine by saying, oh, let's just try a little Benadryl. Let's just try a little more Benadryl. This is like really common in kids with food allergies because nobody wants to take that big needle and stick a kid. Nobody wants to put a needle in a kid. But you just have to bite you have to bite down and just do it because if you get behind that cascade of events that happens when somebody's going into an anaphylactic reaction, get behind the power curve, you can't, no amount of epinephrine that you can administer can reverse that. And so you can die from the delay of giving the epinephrine. So yeah, you can give epinephrine and then give, if you're in the emergency room, they're going to give you IV Benadryl, they're going to give you IV steroids, they're going to give you IV fluids. Benadryl is good, diphenhydramine is good. It is part of the cascade, but it's don't delay and don't go to Benadryl first. Go to epinephrine if you think someone's having an allergic reaction.
But if you don't have epinephrine, pounds of Benadryl.
If you don't have epinephrine, I mean, you can call 911,
Yeah.
but you're already now behind that power curve, so.
The other question is the nasal spray Neffy approved or effective?
It has been approved. Yes, I mean, if people have a real problem with having it injected, it has been approved for anaphylaxis. So yes. Would I use it? I'm an old lady. It's like, I've been around in medicine since the 80s. I want a big 18-gauge needle in my thigh. I just feel that.
You don't want to get even
Yeah.
that.
Does it go through the bee suit?
Absolutely. Oh, yeah, this will go through a lot of stuff, but
Dave's there.
they tell you to be careful not to put it through your own thumb, because several emergency responders I've known have gone through their thumb, and it's quite painful, I understand.
Are there risks to administering that other than
Well, you need,
misidentify?
the Neffy?
No, the epinephrine.
Epinephrine. So, I mean, that's why you get trained on it, because you sort of, it's like CPR, you know, you have to kind of learn the things that you want to understand about it. And if you're gonna administer epinephrine, they recommend you are trained in CPR. The only, it's probably would fall under the Good Samaritan law if somebody got stung by a bee and then just kind of completely fell unconscious, and didn't have any other symptoms, and you had an EpiPen. Nobody would fault you for using that EpiPen, especially if it was that person's EpiPen, because that's a reasonable thing to do. So under the Good Samaritan law, no, but yes, if someone has a bad heart, like in the allergy clinic, if you had a certain problems with your heart, we wouldn't do allergy testing, because if we needed to resuscitate you with epinephrine, we might kill you with it. So, but these are older people usually. Does that answer your question?
Yes.
Okay. Yes,
So one of my stings, I think last year, the year before. When we put out, I think, you know, it was either the second or the third day after, it just, the arm just swelled up. And it was really hot, and decided to the doctor, and oh, we have cellulitis, so we
Mhm.
out and we
Good.
I guess that was.
right. So, yes, you do have to wash with soap and water after you get a sting. But, and so what would differentiate like a cellulitis between like a wide local reaction? So the type of swelling is different. With cellulitis, it tends to be a little softer swelling, but the cellulitis usually takes like 72 hours to really start cooking and get swollen like that. Whereas if it were a wide local reaction after a bee sting, it would happen pretty quickly. Other questions? Okay, great. Well, thank you all for listening to me pound on
Thank
about allergies.
thank you, very great. One more here. Oh, one more question. Can you give more than 2 doses of epi?
Yes, you can give epi until you run out of epi. So,
Or 911.
right, because, yeah, once they get to the emergency room, if they have to keep giving it, they'll put it on an IV drip and they'll put it on a pressure bag, been there. So, yes.
And
But-
you have to hope that doesn't happen.
Not good turnout. Yeah, it didn't end that well, and it's bad.
This
Thank you,
is,
Cheryl. Interesting discussion. I'm going to tell you, as I did last month, that the Pacific Northwest Honeybee Survey is now open. I opened it early, so it's been open in March, but it's also open through the month of April as well. So if you have had overwintering colonies, in other words, not a new beekeeper, this is a way that we can gather information of what's happening locally in terms of levels of losses and what we are doing in terms of some intervention and trying to reduce those losses. This is hosted by this club, by club. Next, please. So this was what I reported last year. So after the end of the survey, I also then take that data and then put a report for the group and usually come back to the meeting and talk about it. So last year for this group, next one, please. PGBA, I'm sorry. 40 individuals responded to the survey, and the level of loss of those 40 individuals was just about the same as statewide of 250 individuals, 25%. This year, next please. 25, 26, next. I have 33 individuals that have already from this group that have put in a survey, thank you. Next. The level of loss is 18%. Okay, and then the next one is of that percentage. I divide the data a number of different ways. The people that are keeping Langstroth 8 frame colonies, their level of loss has been 15% this year, those 33 individuals. For the laying 10s, 24%. We also have some people with top bar hives, some people with wary hives. And unbelievably, this year, all those people with those other types of hives, nukes, et cetera, didn't have any losses. They're not very many in that number. For Oregon, I also do a commercial group, in terms of survey. So right now, running for the us, the backyarders, last year, the 26%, this year in Oregon, 23%. Or that's all of the number, and that's about 350 individuals, for almost 400. The commercial beekeepers have typically been below as even half the level of losses as I started this survey in 2010. But you notice in the last few years, their numbers are higher levels of losses than ourselves as the backyarders. This year, last year, that level was 48. This year, their level of loss is 33%.
It's good.
Okay, so their level of loss again is underwater, is higher than actually. So this is what it's going to look like. The dotted line is the trend line, obviously going in the right direction. So I'm going to be adding 26 when I get the full data set. But at this present point, it's 18%. So it continues that trend line that we'd like to see, the trend line for the club downward, and also for state as well. Next. I have talked about remediation, and it starts now. Starts now because the mites are now growing, and we want to flatten the mite curve. I've been doing a new Beekeeping Today podcast, Bee Science, with myself. Number 3 was issued the middle of this month. And number 4 will be issued next month, middle of April, the 3rd Wednesday. I'm talking the number 3 about integrated pest and pollinator management, IPPM. And this one I'm talking about spring mite control, what we might be doing now with spring mite control. So all that information is available through Beekeeping Today. The middle of April, we'll have a second. Next. Right now, mites are on drones. So this is a developing drone. You can tell from those big eyes, very easy to see. What we recommend is one of the strategies is to remove as many drones as you may from the colony. And then what you're doing is you're eliminating those founder's mites going into the cells before they're capped and then reproducing. The difference is if the mite founders goes into a male cell, she can reproduce 3 mature, on average, 3 mature female daughters. If they go into the worker cells, which they will do once there's no longer drone cells available, the yield would be 1 mature female. So that's why they're reproducing so rapidly now. And of course, the disclaimer is it's not the mites, it's the virus that they're spreading. So we want to get ahead of that curve and not let the mites feed on the pupae, in this case, drones, right now, this time of year, or on the adults. They need to feed on the adults that have the protein material to produce their own eggs for the next generation. We want to flatten that growth curve, keep that development of mites down as low as possible. With that, then the possibility of the mites spreading as much of the epidemic type virus diseases, the deformed wing viruses, the paralysis virus, will also be reduced. So flatten the mite growth curve. Next. For issues with not understanding what might be going on with dead owls or disease, the club has a beekeeper task force. There are several people that are on that task force from previous training. I did that a couple years ago. I'm doing the training again this year if anyone has interest. We do it with a Zoom initiation of going over material that's available. There's a great deal of information that is available that is free that you can use to talk with other beekeepers, for your own self, your own education. And then that also includes in our pub apiary and on Sunday the 12th, a session where we're actually going to be how to look at a colony, how to make a diagnosis of dead owls and beekeeping tests. And that was originated here. And finally, if you're not in the Oregon Master Beekeeper program, I'm the content communication specialist, so I'll be glad to try to talk to you about the Oregon Master Beekeeper program. Next. Our uniqueness is that we put you with a mentor right away, mentor in the club, mentor that's had some experience, and a mentor in you in a minimum of 4 interactions in the year, seasonal interactions. Get a chance to have some other expert people that have been through the same type of thing, help you with you as you are developing your own beekeeping journey, your own skills. Next. And of course, another excellent way to do all this, of course, are our pub open hives. We usually do those the first and third Sundays of the month. However, the first Sunday is Easter Sunday, so we're not having one the first Sunday of April. So the only one we'll have in April will be the third Sunday. So not one coming up this coming Sunday. Okay, thank you. Appreciate it. I have cards with QR code to enter the survey if you'd like, but PNW Honeybee Survey. Brought some cards, as you. Cards. Who's got cards? Thank you.
Dewey, I have a question.
Yeah.
The club got an email today from a group called Environment Oregon. I've never heard of them. They said that last winter, over 65% of honeybee colonies were lost in Oregon. Does that sound right to you?
It's the number is close to what actually happened. We believe in last year with our commercial beekeepers, their level of loss was 62%. In my survey, you saw it was 48%. So somewhere 48 to 50%. 68 is a little bit high. 68 is a national number, not the Oregon number. We were a little bit lower, not that 50% level of loss is anything very low, but yes, we had very extensive losses last year. We did not this year. There were enough colonies for almond pollination. Last year, the nukes were in pretty bad shape that we were able to purchase locally. This year, it's looking a lot better. They came out of almonds much better shape. And the queen rearers are reporting better success with their early mating. So knock on wood, our nukes are going to be in a bit better shape this year. I did one look at one of our groups that was buying nukes last year, and individuals that bought nukes lost 75% of them. And that matches data from one of our other groups. Someone else has done the same. So it's tough starting a nuke. And I think we've got to work a little bit more intently with nuke education. What do you do with nukes?
Those nukes die after purchase or over winter?
These were purchased nukes.
No, did they die soon after like in the summertime, or did they die over winter?
Yes, both. And there were some that just never got to September. There were a number that were reported in October and November as deaths, and then when people went to look at them in the spring, they were dead. So there was a bit of both, and I'm separating that data. There's a question.
Where do you put the cutoff for winter losses? Whenever you winterize your colonies, I'm trying to be good and take my losses in the fall, but obviously that pushes my winter loss rate way down.
Yeah, so we're roughly looking at a period of October, roughly. In other words, the last time we look at our bees in the fall, we had 3 colonies in the backyard. And then in the spring, when we look again, well, one of those 3 didn't survive. So that would be a loss of 1. But now in the spring, if you additionally have loss to, for example, starvation that occur in some springs, then you lose another colony. In the survey, I would like to have you indicate then you lost 2 of the 3.
Can you repeat the apiary day info again? That's another question.
The apiary date info for the task force. I'm sorry, the open hive for pub is the 1st and the 3rd Sundays of each month, but not this month, not April.
Not Easter.
Not Easter. So it'll be the 3rd, which would be 12, 19th, 18th, 19th of April will be our only one this coming month.
Great.
Yeah.
On the commercial losses, how much of that is actually factored in on the commercial side that, you know, it's gonna cost us this much to maintain them? If we let them go, we only lose this much. Is that part of the calculation?
It is part of the calculation. So in the backyard, we had 3 colonies. We can see 1 definitely is dead. 1 is very weak. I'm watching it and maybe it doesn't survive in the spring. So I have 2 out of 3. Commercials are not counting the same way. They have the expectation that they're going to have available for their first pollination rental 5,000 colonies. But they can only come up with 4,000 that are commercially rentable. The others they've got to do combining and everything else. So they're going to call that a loss of 1,000 in most cases. So they count their losses differently than we would count losses. So they're talking about viable colony units.
But they don't have to baby along.
They don't have to baby along. They may be limping along, which for us in the backyard, well, I got one very weak one, but by feeding it and everything else, it survives. That would be a loss for a commercial. They're gonna combine it right away. They're gonna break it right down and make it into a colony that's viable. So they do all that maneuvering around. Instead of 5,000 that they had in the fall, they've only got 4,000. So they'd say that's 1,000 colony loss, 20%. This year it's 33%.
Can I ask one more question? I'm
Yeah.
gonna try Formic Pro for the first time. I've always been a little nervous, but I'm gonna try a single pad. It is a little bit below 50. It says recommends it between 50 and 85. Do you know if that's just daytime temperatures? Is it a little too early for it, or is it okay to probably try it?
So Formic Pro is a very strong acid, and the recommendations are either two pads at one time or one pad followed by one other pad. The reason why that second recommendation is that the two pads at one time are really tough on the bees. It will kill queens, it stops queens from egg laying, and it kills open brood. So it's a real tough. The level that we have to poison them with formic is very close to the level that we're killing honeybees. That's why we get those conditions. However, if you use one followed by one other one, we're also not getting the kill power that we need. And then if you add on top of that we're putting it in at a lower temperature, the lowest our spring temperature, it's also not as effective. It's not being distributed as well. So what our expected outcome would be somewhere in the vicinity of as much as a 75% effectiveness. Lower temperature, we reduce that amount. Depends how long it is lower. There are a number of other factors. When we go to the 1+1, we're reducing that 75% down again. So we still will get kill power, but it will not perhaps meet our expectations of being a real effective treatment. I'm keeping my numbers now.
Okay, thank you.
Any information on the new product Noroa that's using the RNA in sugar syrup?
So a brand new product is Noroa. It is a double-stranded RNA. We feed it in sugar syrup, and it has to be fed so that nurse bees use the majority of the pouch of the feeding of this material. Because the nurse bees are then going to make up the food for the larvae in their head glands. And so that double-stranded RNA will get into that material. So then they feed it to the developing larva for the 5 days that larvae feed. The larva then goes to the pupal stage. And if a founder's mite goes into a cell of a pupa that has been fed as a larva by a nurse bee, all right, so you guys see this whole chain, then that what happens with the double-stranded RNA as the developing developing mites, the offspring of the female, as they are developing, a chain of protein synthesis does not happen. So basically it means she is not able to reproduce herself. So if she's in that drone cell, she can't produce those 3 more fertile females. So if we get it into the nurse bees, enough of it into nurse bees, it can be very effective. Whether it's not the silver bullet, but it is one more, I think, very valuable tool in the arsenal. The double-stranded RNA is a messenger to what the DNA is going to put down, and that's where the problem comes in for the female mite to reproduce. That same message is not in humans, is not in the honeybees. So this material, Noroa, is very specific for mite reproduction and will not then be the nightmare that we have that we're going to mess up our own DNA or we're going to mess up the DNA of honeybees. It's new technology, it's pricey, but it has had 10 years of testing. If you get it in that chain, it is a very valuable tool because right now our number one priority is keeping mites from reproducing. Okay, flatten the mite growth curve. Fewer mites feeding on the bees, less of the possibility that they're going to get this epidemic of the viruses that are going to kill you.
One last question for you. This is my first year of overwinter losses. So what do I do with the equipment? I got 2 hives sitting there. What practically should a beekeeper be doing?
So overwinter losses, what can we do with the equipment?
Yeah.
What we want to try to do is get bees back on it. So try to get a swarm back on it or make a division of one of your stronger colonies.
Plan to do a
Not
split,
immediately, but as the spring is developing.
but it's okay to sit there while I wait to do a split.
So it's going to sit there while you're waiting to do a split, which means if there was any honey, bees will rob that out.
They have
If you want to take and put it in a shelter so it's not getting wet or mold continuing to grow, that's fine. If you want to put the frames in a freezer, that will then preserve the honey that still is in there. That honey is valuable when you put a swarm on or you put a division into that.
If I peeked in there, there's lots of mold in there. I shouldn't be concerned about
We
that.
should, so there'll be a lot of mold in there. It'll be kind of ugly looking. As soon as you put bees on it, they will clean that up. And particularly a swarm, amazing how they will go ahead and make all that real ugly stuff right now into a nice pretty column right away. Question on that?
One more question from the chat. Do you think a 3-round course of weekly OA vape treatments will be as effective as a spring knockdown?
So 3 weekly OAV, oxalic acid vaporization, 3 treatments is not enough. It will knock the numbers of mites down and reduce the growth. But if you want to get them at a lower level, we need to do that for about a month. We need a minimum of 6 to 7 treatments. So every 2 treatments a week for the month with OAV or OAD dribble. Now the alternative is the new product called Viroxan, which is oxalic acid extended, OAE. And the issue with that is that oxalic is kept in your colony continuously and bees walk over it continuously. And to kill mites, oxalic acid, a weaker acid, has to actually contact the mite itself. And so if the bees walk over it and then there's enough on their body that the mite then goes on to their body, then they will be killed by the oxalic acid. So the advantage of OAE, the extended oxalic acid, is you have that in your system for at least a month. These pads that we make up or the Viroxan will last a month to 6 weeks. But if you're going to do the vaporization or you're going to do the dribble, 1 is not enough. 3 is going to help some, but is not enough. You're going to have to double that and do that like within a month's period of time.
I heard that it's better to put the Viroxan laying it across the top of the frames as opposed to folding it and putting it down. Is that?
So the product Viroxan is designed to be a frame draper that drapes over frames. You put 1 in for every roughly 2 frames of bees, active bees. The pads that were developed through the research with scientific beekeeping, Randy Oliver in Nevada County, California, were pads that sat on top of, they were sponges that actually sat on top of the frames. And it turns out that the bees are going to walk on the frames sitting, the sponges on those are going to walk on those more than they're going to walk on the hanging strips. So those is actually a more effective way. So the question is, so if we take the hanging strips, but lay them flat on the frames, will we get the same level of control that the manufacturer claims by draping them over the frames? Short answer is yes and no. The only study really that's been done, Randy Oliver, it's in this month's American Bee Journal, is he had failures of 2 of 6 colonies when he laid them on the frames rather than draping them. He doesn't know why. He did not. So just a little bit that many people are not draping them, they are laying them, but you might not get quite what you expect, in terms of level of control. But the idea is to keep the oxalic acid in the colony for a longer period of time, a month, a solid month. So that's why you would vaporize twice a week or the whole month. It only kills the mites that are on the adult bees. And so they have to contact it. The bees have to get on the material, get it on their body. The mite then transfers from another bee onto a body of a bee with the oxalic acid crystals on it, and it's gone. We don't know why it's gone, but it's gone. One more.
One more question and I'll let you go. We'll close it down. What are the indicators it's time for Noroa?
What indicates time for Noroa? Your bees have been through a flush of brood. You now have lots of bees emerging, lots being 2 to 3 frames of emerging adults. They've gone through that much brood already. That there is nectar coming in small amounts. We're past pretty much the big leaf maple, and then we're into the mustards and all the other stuff that's in bloom. The colony is now expanding from like the 3 frames to as many as 4 or 5 frames. In other words, the queen is laying a lot of eggs, and there's a great need for nurse age bees to then feed those developing larvae. If you do not have very many larvae, you got your colony is a weak one, it's slow getting started, you're probably going to waste the effect of the Noroa. You really want to have a flush of nurse bees and lots of larvae with a prolific queen that's laying those eggs, because now there's a lot. So weak colonies wait a little bit. If you have a very strong colony and you see that they've had a lot of brood, it's emerging, the queen is going back to the same frame and laying eggs back in those very same cells that have been cleaned, that's a good sign then for Noroa. We would not want to feed it later when there is a good nectar flow, because the bees are going to store it in the honey. So it'll never get to the nurse bees, never get to the larva, never get to the pupa, and so it's not going to be effective. We think we can also feed it in the fall, as the bees are rearing the bees that are going to get through the winter, what we call our fat winter bees. We think there's a window there as well in which it will work. The problem is, after the peak population, things can very rapidly decrease in terms of the amount of brood. And so there isn't much brood then to feed, and so then the nurse bees aren't going to get into the larva. But certainly spring, but not first thing in the spring. If you've fed it by now, you've probably wasted the money that you spent on it, unless they were very strong colonies. So wait to get that colony and let it get going. Okay, thank you.
Thank you. Good night, everybody online.